Good morning, everyone. Today we are going to discuss about perioperative management. So, what is the importance of this topic? First of all, we will discuss about that. Now, still, all these lectures are of general surgery, so that is just to develop the basics of surgery, and that's why um, we are overviewing, you can say, most of the basic surgery topics during these lectures. So now there are three phases you can say of surgery. One is called as uh, pre-operative, what you can say, phase, and then there is intraoperative phase, and then there is post-operative phase. So um, together these three, they are called as perioperative management or phases. So basically, you can say that pre-operative care or pre-operative phase and intraoperative phase and post-operative phase, they are the phases of perioperative care or perioperative phase. Okay. So anesthesia and procedure are basically called as intraoperative phase. Okay. Now, what is pre-operative care now? Pre-operative care is uh, basically preparing any patient for the surgery. For example, right when the diagnosis is done, and later on of diagnosis, we take the clinical history of the patient, and then um we do the diagnostic workup. We do the pre-operative evaluation, and we prepare the patient uh, for the surgery. Now, again, I want to emphasize this thing that um, not all the cases are same. For example, if someone a fit and healthy teenager is undergoing a appendectomy, of course, preoperative care is uh, very simple or very easy. But whereas if you can say a 65 years old age of patient is undergoing a colon surgery, for example, who is having some heart condition and who is a diabetic and who is hypertensive, who is taking 3 4 medications, so of course the pre-operative management will be different. So in this phase, simply we take the clinical history, we do all the basic laboratory testings, we do radiological imagings, and then like what they do, they see either they are going to encounter any potential problem. For example, um, maybe the patient have some other condition, okay, like heart condition or anything XYZ condition. So they are going to look in that. So one of a very important thing which is a part of preoperative care is like consent from the patient, explain the procedure to the patient, explain the procedure to the family if needed, tell them the risks, tell them the benefits, tell them the most common risk, or you could say complications, right? Tell them like uh, how much time it is going to take, or like not exactly, but like approximately how much time is going to take, plus always tell them the possible alternative approaches. So That's very important. So, of course, in reality, like in the hospitals, they give a lot of forms, consent forms, in which like the patient signs, including the anesthesia side effects and all this stuff. So, just like you should understand right now at this stage that that is also that includes in this phase. So this phase, this is not just the surgeon, rather there is anesthesia fitness, which anesthesiologist will do, the surgeon will do, will evaluate the patient if needed. For example, the patient is diabetic, so maybe endocrinologist will play a role, or maybe if the patient have some heart conditions, so a cardiologist will also play a role. So you can say like it's a teamwork, it's a multidisciplinary approach. So that is like all preoperative phase or preoperative care. Then comes the intraoperative. Now, uh, this one, of course, we cannot discuss here because, like, it depends, completely depends what the patient have and what kind of treatment or what kind of surgery is going to take place. So uh, that is just this thing. But like simply, one very important thing in this one is um, like everything should be documented so that there should be no like doubt about anything. For example, if the surgery is done on the right leg, so it should be clearly written on the notes, and x-rays should be there and everything, because humans are doing all this stuff, so there should be no confusion in handling any patient. Okay. uh, because like in hospitals, of course, there are many errors, which can take place. There are many jokes on that as well, by the way. So uh, then, of course, uh, in an intraoperative phase, every surgery have its own specific posture. For example, a tonsillectomy patient will be laying down in a different way, mm, gynecological patients in a different way, laparotomy patients in a different way. Someone who like in which they have to do surgery on the back, so of course like he will be laying down uh, prone. Okay. So I would rather like to tell about whenever any surgery is taking. So like in the surgical room, there is always the surgeons, uh, the main surgeon, the assisting surgeon, the anesthesiologist. Then there are many nurses. Uh, so there is a lot of staff like there, which is at the time of surgery is present over there. Yeah, and also sometimes we need blood during surgery. So of course, in this preoperative care phase, you can also ask for the blood, so that a blood should be arranged beforehand. Yeah, because if they need in the surgery, they can use that blood. So like this thing. So now in this one, of course, you are going to study anesthesia as a different subject. So you are going to study in that a lot of things. What kind of drugs they use, what kind of muscle relaxants they use, and how they induce, how they maintain, and all the stuff. So that is all anesthesia things. But like, of course, we are doing studying surgery. So of course, like we will talk about the surgeon's responsibility. Of course, like it's they are responsible to perform the procedure with the skill they have, with efficient skills they have, and the procedure should be go uncomplicated. Okay. Like they should try that it should go uncomplicated. They should follow all this protocols, all the safety measures, and all this stuff, right? But of course, during the procedure, the surgeons, they communicate with the anesthesiologist and with the rest of the team, because they have to update them, like how long the surgery is going to take place, and what is the vitals of the patient. For example, what is the oxygen saturation, what is the pulse rate, what is the blood pressure. Of course, like it's a teamwork, you can say it's a multidisciplinary team. um, and then like in this phase, there are different complications which can arise, of course, during surgery. They put a lot of instruments inside the patient. They put a lot of spawns, for example, inside the patient. They like for the surgery, they put a lot of foreign bodies inside the patient, which should be removed, of course, before closure. So there is something called a sponge count as well, like how many spawns they are putting in. They keep on counting, not just for the one person, but rather multiple persons, so that when they are closing, so they must do the sponge count. Because when they are putting the sponge inside, so of course, due to blood, they become bloody. Sometimes it's hard for the surgeon to identify. So there are cases in which like they forget a sponge or a something like some foreign body simply like inside the patient, and then of course like they reoperate and take it out. So anything can happen. So anyhow, like this is the intraoperative phase, and then comes the post-operative phase. Of course, like uh, after surgery, uh, uh, like right after surgery, you can say, because until the patient, they are under the effect of anesthesia. First of all, they move them mostly into the uh, intensive unit, you can say. So after that, they like once they know like the condition is stable, then they move them to the some other place, to their rooms or to their wards, and then there is like follow up, like acute follow up, or you can say then there is a long term follow up, like to see the chronic complication. So simply, you have to see, we have to check, do the post op observation, and then like we have to see for an initial complications, and then for chronic or long term complications. So of course, like in the initial period, we have like the surgeons, they take care of the pain. um, they see either the patient is developing any kind of fever. uh, there are chances of stroke, myocardial infarction, airway obstruction, acute hemorrhage in many cases. Some and of course, like patients need a lot of fluids after the surgery, so they provide them. And like this, and then of course, like after discharge, they keep on checking the wound. They keep on checking like either the patient is developing fever, for example, something called as post-operative fever. We will discuss in this lecture. So they look for all these things. So that is like the part of the post-op care or post-op operative management. Okay. So now the most important thing to understand is what? Remember, like every surgical process carries some risk, okay? Carry some complications. It's not like this, like every surgical process have complications. I'm saying like they carry some complications, okay? So, and it's not like this, like every patient will get the same complications. The patients can get different complications. Very easy way to remember some of the surgical complications. For example, surgical patients may have bleeding, a very common complication. They may have infection. They may have, like you can say, during the surgery, they can damage the adjoining structures, things like this. Okay, like these three are the complications which are the complication of any surgery you will do in the body. Uh, but like some, and then there are some specific complications depending on the surgery they are performing. Okay, and one of the things like which we know is like some of the group, or you can say population group, they are at more risk of having the complications than the other group. For example, um, you can say the elderly patients, the patients who are too old, they get more complications. Okay. Also, you can say the patients who are too young, they get more complications. And also the patients who have, you can say, too many comorbidities. What is comorbidity? Is simply like someone have diabetes, heart conditions, liver disease, renal disease, and all this stuff. Of course, like they have more chances of complication, okay, like due to surgeries, simply. So now, um, the important things to talk about, like we will start discussing. is okay. Who are the people and what are the factors? See, okay, many of these slides, by the way, they are taken from Bailey's, okay, Bailey's book of surgery. So even like I think like this one even because like I made the slide many years back, 3 4 years back, 4 5 years back, by the way, and I think like Bailey's the layout is like this. Okay, so the important thing is to what this thing is the detail. You can say in the preoperative patient preparation, we gather the record concise, concisely, devise a plan to minimize risk and maximize benefit for the patient, consider possible adverse events and plan how to deal with them, communicate to ensure that everyone, including the patient, understand the surgical plan. Okay, why we are doing this thing? Simply, guys, we have to catch or identify the high risk patients. Okay, like again, I'm giving you the same example. Maybe I'm third time I'm talking about the same example, but this is important because again, I told you, elder patient having some heart condition who is undergoing bowel surgery, and especially like emergency bowel surgery. So of course, the risk of complications can be very, very, very high, right? Rather than a young teenager who is undergoing appendectomy and it is an elective one. So of course, the risk of surgery, surgical complications can be very, very, very low. Okay, so that's the important thing. Okay, so uh, again, we take the history, right? So we do the history, we do the clinical examination. So you can see, like, listen, what does the patient see as a problem? Like, okay, this thing is like too basic, and I don't know, like when the regular classes will start, so I can teach you these things directly face to face in the class, like how to take history, for example. We start by asking some open questions. For example, uh, to many who don't understand what is open question, let me explain you. See, if you have a patient who is presented to you and he's saying like he have pain in tummy, for example, so if you will ask like where is the pain, so you are pinpointing the question at one place, where is the pain. So maybe the patient will say, okay, here's the pain, and then you will ask like uh, where it radiates, or what is the severity, what is the aggravating, like XYZ, any question. So this process is more time taking, um, and maybe you are going to lose a lot of information, or maybe you will forget to take a lot of information. So if the patient is coming with pain in the tummy, you can say, for example, you will say to the patient, tell me more about pain. So see, now this is an open-ended question. So now I am giving him a big field to play. When I will ask him, can tell me more about pain. So maybe he will say that, the pain started yesterday, it was before here, then it started moving here and there, and the severity is changing. So like XYZ, whatever. So that's why I start from the open-ended question, and then for your clarification, uh, you can ask some close-ended questions. For example, if the patient is saying that okay, the pain started here and there and whatever, so like maybe I can ask like, is the pain or did the pain is hurting your back as well, or stuff like this, right? So I'm asking a close-ended question just to refine my search, right? And then we can ask the focus questions to narrow down the differential diagnosis. Uh, and then we can ask some fixed question, for example, to check the comorbidities, like do you have diabetes, do you have hypertension, do you have this, or do you have any family history of this thing. So like this thing, right? So you can see like here it is given features of the history of the presenting complaint to explore, like symptoms, onset, relieving factor, exacerbating factors, the pain, the nature of the pain, any radiation, other therapies, planned surgery, and expectation. So again, like they are giving you a layout. Okay, what are the things to ask? So anyhow, uh, next one. Okay. Now here is like again, guys. Now I'm confused. Really, it is taken from Bayless or not? But this one shows you that what are the things you can ask in the past medical history. Okay, so now you would be thinking that these are too many things. So what you will do, or what, why I'm showing you this thing? But the important thing here is to talk about is what. See, um, all these things or all these things can impact the surgery number one, or impact the surgery outcome. So it's better to inquire about all these things, like, do you have angina, do you have myocardial infarction, do you have hypertension or heart failure history. uh, you can see COPD, asthma, ILDs, malignancies and peptic ulcer, bowel habits, liver disease, malignancy, UTIs, epilepsy, for example. So see, I'm just scrolling, like I'm just scanning it, diabetes, thyroid dysfunction, osteoarthritis. So okay, all these things can basically impact either the procedure, or either they can impact the surgical outcome. So whenever we explore the past medical history, we must look at all these things. After clinical history, we go for examination. And when we go for examination, of course, we do the take the vitals, then we do the GPE or general physical examination. We look for anemia, jaundice. Okay. The good thing, you all have done physical diagnostic classes. You know what is physical examination, and you can see over here, nothing different is written. Like, just these are some key points, um, talking about different systems and what are the important things to see in those systems, right, from surgical point of view. So let's say, for example, in GIT, you will like look for the abdominal masses, SITs, bowel sounds, bruits, hernias, and genitalias. So if you know the GPE, so simply before surgery in surgical patients, they go for physical examination, and uh, it's not like this that we examine everything in the patient. Rather, it's like this that we, for example, if it's an emergency, so I'm going to do a focus examination. Okay, so depending on the condition of the patient. Then, as I told you, we go for the investigation. We do the basic investigations like full blood count, urea electrolytes, liver function test, clotting screening, ABGs, electrocardiography, chest radiography, and further cardiac evaluation. Okay, now it's like the general things which are written. Rather, I would say that it depends on the surgery, the type of the surgery you are performing. You are going to mold your examination or the investigations according to that. Okay, so maybe you will not do all these investigations in a patient who is undergo appendectomy, but you will do these investigations plus some more for a patient, again, an old patient who is undergoing some serious surgery and who have a lot of comorbidities, right? So like you can see over here, for example, uh, if ejection fraction is less than 35%, okay, so there are the mortality, the chances of getting myocardial infarction or the mortality is very high in that patient during the surgery, right? So this example here is just to emphasize or just to tell you the importance of pre-operative investigations, right? Okay. Then you can see over here uh, some more tests which are written, right? Which can be done, not done in all the patients, but which can be done. Okay, so now what I'm going to talk about is a very nice table. Uh, Let me clear one thing now. I think this one is taken from USMLE Kaplan's, right? Uh, you don't have to memorize this, right? There is no point to memorize this table, but you must make a concept. Uh, Now, see, this is a specific preoperative problem. Someone who have a cardiovascular disease, right? Someone who get a cardiovascular disease. This table is called as Goldman Cardiac Risk Index, and you can see over here. Here, what is written? Cardiac complication rate. See, if someone have a third heart sound, like before surgery, if you are checking some patient, you are evaluating a patient, you found that they have a third heart sound, or a recent myocardial infarction, or some arrhythmia, okay, some arrhythmia, or his age is less than more than 70. Each thing carry different marks, okay. For example, someone had a recent myocardial infarction and he had a third heart sound. The score is will be how much? 10 plus 11 will become 21. Come here. If someone is getting 21 points, so it means there are 40% chances of some cardiac complication during the surgery. So simple. Again, you don't have to memorize this, but you must know the concept of this table. And I am showing you just to give you the concept of this table. So see, a 70 patient who is more than 70, who is have recent myocardial infarction, who have a third heart sound, if he is undergoing surgery, his score will become 26. See the mortality, 78%. Okay, so the table works in this way. So this table is not important for you, but this table is very important for the anesthesiologist. This table is very important for the cardiologist who is evaluating a patient for some surgery. Okay, let's go to some other slide. Okay, so of course, like here again, some, for example, sorry, well, just to tell you the importance of this pre-operative evaluation. Uh, Someone who have a JVP distension, like congestive cardiac failure, it is the worst indicator of cardiac risk. Treat with diuretics, ACE inhibitors, digitalis, and beta blockers. Someone who have a myocardial infarction, the mortality is 40% within 3 months, decreased to 6% after 6 months. So see, now again, this is a very good example for a patient who have to undergo some elective surgery, not emergency surgery. Of course, emergency surgery in which like the matter is to save the patient, of course, you will go for the surgery. But for example, if a patient is going for some elective surgery and he had a recent myocardial infarction, see the mortality is so high within the first 3 months. But if you will delay the surgery up to 6 months, the mortality is very, very, very low. Okay, so see, if you will delay that surgery, the mortality will be very low. So that's why it is written best to defer the surgery if possible. Some more examples of pulmonary risk. See the smoking. Now smoking, as I was discussing in the previous lecture, when I talk about what you can say, I was talking about in one lecture about the pulmonary complications, right? So in pulmonary complications, I told you one thing. For example, I told you that whenever someone is undergoing surgery, so what we do is like we ask the patient that okay, try to quit smoking, right? Why quit smoking? Because someone who is a smoker, he may have, for example, um, atelectasis or pneumonia and things like this, right? So when you will ask the patient, for example, to quit smoking, what will happen is, like, of course, like, you are going to uh, decrease the chances of them uh, getting and some of these complications. Okay, so that's why we ask them to quit smoking. Okay. Okay. So now you can see, like, increased pulmonary risk, compromised ventilation, high carbon dioxide in their blood. Okay, and then there is low FEV1 they have, forced expiratory volume in 1 second, and see, this one is like COPD they may have. So smoking cessation for 8 weeks respiratory therapy is mandatory for these patients. Why? Because this is going to decrease the chances of complications too much. Okay, so that's why anyone who is smoking, try to tell them like, they should quit smoking at least for eight weeks before the planned surgery. Gives you the best results. Okay, see the hepatic risk. Again, these are the examples just to make you understand why preoperative evaluation is more important, and why our aim should be to catch the high risk patients. Okay, we should not do surgery on any high risk patients, because maybe you will do less good but more bad for that patient. Okay, so um, if someone bilirubin is above 2, albumin is below 3, prothrombin time above 16, or encephalopathy, the mortality is 40%. Okay. Whereas if you will see, like, if 3 of above, so this one is either either like someone who have like bilirubin above 2, 40% mortality, just albumin below 3, 40% mortality, prothrombin time above 16, 40% mortality, or someone who have encephalopathy, 40% mortality, right? So either, that's why this word either is written over here. But if someone have 3 of the above, for example, someone who have this bilirubin above 2, albumin below 3, and prothrombin time above 16, the mortality is 80 to 85%. Now the most interesting thing is this one. If you have a patient who have all these things, whose bilirubin is more than 2, whose albumin is less than 3, who have prothrombin time above 16, and he have encephalopathy as well, see, the mortality is 100%. So for sure, any patient who have these 4 things together, if the surgeon is going to perform a surgery, the mortality is 100%. Or you can say either 4 of these, or his bilirubin alone is more than 4, albumin alone is below 2, or blood ammonia alone above 150. So you understand, see, if someone have dearranged liver function testing, so performing surgery would be disastrous for that patient. So this thing is important. Then there is a nutritional risk. You can see, like, uh, what we do to check the nutrition of the patient. We check their weight, we check their skin thickness, we check their, we do the bloods, like we do calcium, we do vitamin D, we do albumin levels, okay, things like this. So you can see uh, anyone who have like loss of body weight or albumin is less than 3, so we must give them some nutritional support pre-operatively, okay, to improve their nutrition. Just before performing surgery, we must give them nutrition, okay. So that's a very important thing. Now see metabolic risk. So diabetic coma is absolute contraindication, and rehydration, return of urinary output, and at least partial correction of acidosis preoperatively is important. So anyone who is having diabetic coma, we must treat them and then go for surgery. Rather, uh, if you will go for a surgery, of course that could be proved that disastrous for the patient. Okay, so again, until here, guys, uh, whatever we are discussing until now is all about, you can say, preoperative uh, care, right? So, and the fun of some of the examples I gave you, like, right, like what is the cardiac risk, why we do blood testing, what is the need of that, and uh, what are the things they see or they see in the patient to catch the or to identify the high risk patient. Okay, so operative care, of course, as I told you, you will do study anesthesia, you will cover this thing over there. So see, you can say pre-operative checks with the patient, patient name should be checked, condition consent should be taken, all investigations should be available on that day, sepsis, pre-existing complications should be known. Okay, and see the tasks of the anesthetist during anesthesia is muscle relaxation, pain control, and unconsciousness, minimize blood loss, temperature, we must avoid hypothermia, or he must avoid hypothermia, and they should monitor the patient so that the patient is safe. And uh, of course, like this is again a duty of the surgeon and the anesthetist both, that they should make sure that the patient condition is good for surgery, and ensure that the patient knows what is going to happen, coordinate with the team, participate to the in the collective duty of the team to protect the patient from harm, and supervise the safe recovery of the patient from anesthesia and into the recovery period. Okay, so after that comes the this one, this chart. Okay, this chart I include. Okay, this one is basically what is ASA. ASA is American Society of Anesthesiologists. So American Society of Anesthesiologists, they gave this table or they gave this scoring. So you can see ASA 1, ASA 2, 3, 4, 5, and 6. So American Society of Anesthesiologists, basically they gave the score, and it's very helpful. This is simply to label someone or the patient, uh, like the patient is a high risk patient or a low risk patient, or he's not at all a patient. Okay, basically this is not the only scoring, but this is very easy scoring and used worldwide. There is like some other scoring system which do exist, right? But uh, like no one is going to ask you about those scores. Being a basic student, you must know ASA, right? What is ASA and what they do. So like there is a possum score and all this stuff. So leave that. ASA, American College of Anesthesiologists. Okay, they give this thing. So now you can see over here, ASA 1 is a healthy fit patient. ASA 2 patient is a patient with mild systemic disease like controlled type 2 diabetes mellitus, or obese patient or a smoker. ASA 3 is a patient with severe systemic disease like COPD, diabetes mellitus. ASA 4 is a patient with incapacitating disease that is constant threat to life, like unstable coronary artery disease, renal failure, things like this. And ASA 5 is the patient who is not going to expect to survive 24 hours without surgery, like a patient who has ruptured abdominal aortic aneurysm. And ASA 6 is a patient who is declared brain dead. These are the patients, of course, like they are just there to donate their organs, and once they have donated their organs, what they do, like they remove the life supporting machine. Okay, so for emergency operations, they add the letter E. So if you will find on any patient file that written as ASA 1E, what it means, like he is a fit healthy patient, but they are performing his surgery in emergency, right? This goes like this way. Okay, then comes the post-operative period. Okay, I'm not going to discuss the stages like where they take the patient. Rather, I will tell you a very important topic, that is called as post-operative fever. Okay. Simply, whenever any patient have post-operative complications, so post-operative fever is one of them. Okay, what are the causes of post-operative fever? There is a mnemonic, by the way, to remember that and very easy mnemonic. It is called as wind. What like they all start from W. Uh, like there is uh, wind, water. Uh, then there is pills. Okay, then there is wound, like this. So basically, like, you have to remember the things like this way, that any patient. Okay, before going on that, by the way, yes, I would like to talk about this thing. See, any patient who have fever in the post-operative period, it could be a side effect of the drugs. Like halothane is used for anesthesia, succinylcholine is used during the procedure, during like anesthesia guys, they give this drug. So one of the side effect of these drug is malignant hyperthermia. The temperature goes more than 104 degree Fahrenheit, and the patient uh, like it could be life threatening, right? So the treatment is like, for these patients they give IV dantrolene. Dantrolene is a drug which they use. They give 100% oxygen. They treat the acidosis, and they use cooling blankets to cool the patient. And one of the complication of malignant hyperthermia is myoglobinuria. Like the muscles, myoglobin is released from the muscles, and they can go and they can damage the kidneys. So this thing can occur. So now you can see over here. Then there is bacteremia. What is bacteremia? Of course, like when there is emia, it means in the blood, and when there is this bacteremia, like the bacterias are in the blood. So now you can see over here, anyone who have bacteremia, they may present with chills 30-35 minutes after invasive procedure. So simply, any patient who have this bacteremia, when they present with chills and rigors, what can be done for these patients? Okay, before starting antibiotic, always take the blood sample. So when they take the blood samples, they send it to the lab, of course, like to check what kind of organism is that. Okay, uh, and uh, of course start with them with antibiotics, right? So okay, now this is the topic which I was talking about, and I was talking about, see, there are 1, 2, 3, 4, 5, and 6 complications, right? So uh, it's a very easy mnemonic, by the way. You just have to remember W's. What I'm saying, you have to remember the W's. Okay, so what WC? Atelectasis, as you know, what is atelectasis? Uh, atelectasis is, it can occur in on the first post-operative day. Okay, it can occur in the first post-operative day. So any patient who is presenting with fever, first post-operative day, think about atelectasis. Okay, atelectasis, in the bracket I am writing wind. Remember, lungs. Okay, wind goes in, wind go out. So wind. So pneumonia can occur at the third post-operative day as well. Okay, so you can see third post-operative day, pneumonia can occur as well. So I will also write wind in front of this, right? So atelectasis or pneumonia, both are related to lungs. They can give fever in the first 1 to 3 or 1 to 5 days of after surgery. Then come the UTI. So what is UTI? It is urinary tract infection. So remember water from this. Okay, remember UTI from water. So when water. So, okay, UTI can occur from third day to fifth day. So I have written over here third postoperative day. And then comes, remember, we ask the surgical patients after surgery to walk around. Why walk around? So that the blood should circulate. Okay. And there should be no clot formation. Also, we put the patients on heparin to decrease the chances for clot formation. So remember, walking. Wind, water, walking. So deep vein thrombosis or deep vein thrombophlebitis can occur, right? So deep vein thrombosis, remember DVT, okay, walking, okay, it occurs in leg. Then comes the wound. On the 7th postoperative day around, if they have fever, so always check the wound, because okay, not just the wound, but rather what's inside the wound. Of course, like wound, there could be abscess formation, right? So see, wound infection or abscess formation, it is all related with the wound, right? So they can get fever. Okay. And see, so wind, water, walking, wound, and the last one which can give uh, fever, but I mentioned here the first one here are the drugs. So what I will do, I will add one more thing over here. Remember guys, when you cannot find any one of these, so always review the drug chart of the patient. So remember wonder drugs. This is just to remember the mnemonic. So that's why I put wonder drugs. So all the W's: wind, water, wound, walking, wonder drugs. So many drugs have the side effect as fever. Like many drugs have the complication, their complication of their side effect as fever. So any post-operative patient, whenever they have fever, we always go for these things. See, on the first day of post-operative surgery, I will think about atelectasis. First, second, third day, I will think about atelectasis. I will think about pneumonia. Okay. Then, or for example, a patient who have fever, for example, after 1 week, I will check atelectasis. I will check wind, pneumonia. I will check urine, either they have any UTI. I will check their legs. I will do Dopplers to see either they have any DVT. I will check their wound, either they have any wound infection. I will do the look, feel, and move thing. I will inspect that. I will inspect for any erythema, any tenderness in that area, any warmth in that area. And then I will see for any abscess. Nowadays, we have ultrasonography. We can see the abscess if the patient is having any abscess. And I will review the chart of the patient. What drugs the patient is taking, because many of the drugs, their side effect could be fever. So it's very easy to remember. W's. What are the W's? Wind, water, wound, walking, and wonder drugs. Okay, this is the mnemonic. 5 W's. You have to remember them. You can remember the post-operative complications, right? Very easy to remember. So see here written, like, first day, third day, third day. UTI doesn't mean like exactly on the third day. It could occur any day from the third day, fourth day, or fifth day. DVT can occur, for example, on the fourth day, on the fifth day, on the sixth day, on the seventh day, on the eighth day. Things goes like this, right? This is just to give you an idea, okay? Or you can say the average time of developing these things. Okay, so this is about post-operative fever, post-operative complications. There's post-operative fever. Okay, so quickly we will go on some other symptoms, and we will discuss like what symptoms when we found and what things we can think of. For example, you can see over here chest pain, So many patients, they have, during the surgery they may have MI, most commonly by hypotension. So of course, like during the surgery, they were attached with the ECG monitor. So if they found any ST segment depression or things like this, it can occur in the post-op period as well. So the mortality is high, by the way. When someone have a normal MI or someone have during the surgery they have MI, so the mortality is different. So simply, guys, remember this thing. It will be managed same like how a normal MI should be managed. Pulmonary embolism, I have discussed before. It is one of the respiratory complication, 7-day post-op. And remember one thing I told you, PE or pulmonary embolism and DVT, deep vein thrombosis, are considered as the same disease. And in internal medicine, you are going to study pulmonary embolism in detail. Aspiration we have discussed. During surgery, the patient may have tension pneumothorax. It develop in traumatized lungs, positive pressure breathing. Okay. Tension pneumothorax, again, you will study in detail in surgery, right? So remember, of course, like it's one lecture about all these things, so I cannot talk about all these things, like especially about those things which will come again. Like in surgery, you will study tension pneumothorax in detail. So, like in special surgery, right? So, of course, like this topic should be covered over there. Okay, so the patient may have disorientation or coma. And now, any patient who have disorientation or delirium, okay, I will add one more thing over here, delirium. Okay, delirium. Okay. Okay, so any patient who is disoriented, who have delirium, or who is in who get coma, of course, there are many things to check. For example, check their oxygen levels. Okay, ARDS, like adult respiratory distress syndrome, they may develop disorientation, delirium as well. There is something called as delirium tremens. What is this? Uh, Alcoholic patients who drink a lot of alcohol uh, during surgery or after surgery, when they cannot drink alcohol, they may have started fitting, or sometimes they may started feeling like the insects are crawling on their body. So that is called as delirium tremens. So how it is treated? We give them IV benzodiazepines or IV alcohol. Okay, rest, guys. Okay, now you will see over here, see, anything can occur. Hyponatremia can occur. Hyponatremia can occur. See, sudden can cause confusion, convulsion, and coma. Remember, sodium abnormalities affect the brain. Potassium abnormalities affect the heart. So it can be prevented by addition of sodium in IV fluids. Hypernatremia can occur. Okay, and ammonium intoxication can occur in the patients as well. Okay, one of the thing, uh, after the surgery, one thing which can occur is called as post-op urinary retention. Like difficult to avoid. The patient cannot urinate, especially in the patients who have undergone surgeries around the abdomen or the pelvic region. So for that, what can be done? Catheterization can be done. Okay, and like of course, like to evacuate or to empty up their bladder. So some patients, they may have low urinary output. And what is low urinary output? When the urine output is less than 0.5 milliliter per kilogram per hour. And whenever someone have this thing, we give them fluid challenges. We give them IV fluid like 500 ml stat, and we see like either they pass urine or not. This thing can be done. Now, abdominal surgeries, the patient may present with abdominal distension post-op period. One of the things is paralytic ileus. It occurs in first few days in abdominal surgery. They don't have bowel sounds. They cannot even pass the gas, and it is prolonged by hypokalemia. So always correct potassium levels at this one. There could be mechanical bowel obstruction. One of the things is called as Ogilvie's syndrome. It occurs in elderly patient after surgery, and their abdomen become very much distended and large. Okay, and when we do x-ray, we found a massive dilated colon. So what can be done for these patients? They pass them with a rectal tube to evacuate that. You can see like wound. Okay. uh, Now, this is very important, um, the area, again, this is a complete topic. uh, Whenever surgery is done, and like they suture the wound, they close the wound. Now the wound can get infected. One of the things, the wound can can pop open, you can say, by cutting through the sutures, because of, for example, and when the edema is developed inside, and there is pressure on the wound, pressure on the suture, so anything can happen. So see, wound dehiscence can occur on around the fifth postoperative day after open laparotomy. And one of the things which occurs is like there is large amount of pink salmon colored fluid. So in these cases, like what they do, like they do a reoperation, they fix it, right? And what is evisceration? Simply when the viscera of the abdomen come out through the wound. Okay. So of course, like that is an emergency condition in which like they take the patient back to the operating room, and they operate it. They close the abdomen, or they decide like what to do. So sometimes the wound can get infected, sometimes even abscess can be formed. So of course, when the abscess is formed, drain that. If the wound is just infected, antibiotics should be given. Okay. Fistulas can form in the GI tract. Okay. And the last thing, post-surgical period, any type of fluid and electrolyte abnormality can occur, as I was telling you, because most of the patients, they cannot take anything per oral. Of course, we replace the fluids. We have already discussed how to replace the fluids, what is the daily requirement, and things like this. So see, uh, anything can occur, ranging from hypernatremia to hyponatremia, and from hypokalemia to hyperkalemia, or metabolic acidosis or alkalosis or respiratory acidosis or alkalosis can occur. So of course, like uh, again, like in the previous lectures, I was talking about this thing, that guys try to uh, uh, read about that. Okay, what is acidosis, what is alkalosis? Very, very, very important. Okay, why very important? Of course, like uh, they will give you a huge concept, and this alkalosis, acidosis, or these kind of things will not leave you. Even if you want to leave them, again, like they will come on repeating again and again in internal medicine, in surgery, everywhere, right? So you can see like here, of course, just one points are written, because uh, otherwise this slide can reach more than 500 500 slides simply. So that's why, like hyperkalemia, you can see like I just put few points on metabolic acidosis, like diabetic ketoacidosis, lactic acidosis, or correct underlying cause and bicarbonate therapy, or metabolic alkalosis, like loss of gastric juice, excessive bicarbonate infusion. So really ammonium chloride is needed, right? So I just put one point, uh, because I just wanted to here to tell you like these things can occur. Or same thing with hyper or hyponatremia, or hypo or hyperkalemia, right? And how they can be corrected. But here again, very little details are written. So in the books, of course, too much details are written. So you can review that. You can know about that. So thank you so much, guys, for listening. I will see you around next week. Hope you understand and enjoy the lecture. Bye.